I am Paola Berberino, and I am the Chief Executive Officer of Alzheimer's Disease International, and I am delighted today to be joined by some wonderful panelists. Next slide, please. I would like to thank our sponsors for the day and for ADI in general. So thank you very much to our sponsors. Today we have many people registered from 112 countries. So there's quite a lot of you today. So thank you very much for participating. My next slide is about ADI. We were established in 1984. We are an umbrella organization of 105 Alzheimer's and dementia associations around the world. We represent our members and all of you at the WHO, at the UN, at the OECD, and other global and regional bodies. And we are the promoter of the World Alzheimer's Month and the publisher of the World Alzheimer's Report. I also would like, next slide, please, to remind you that our vision is prevention, care, and inclusion today, whilst we wait for a cure tomorrow. We also are a charity, so always, as ever, I remind you that we welcome any donations. Thank you very much. And I thank all of you that have given to us in the past. Next slide, please. Now, today we are going to speak about the World Alzheimer's Report 2024, and I am going to be joined by some fabulous panelists that I will introduce in a second. But before I do that, I'm going to remind you of what are the top line findings of the World Alzheimer's Report 2021, which was on attitude to dementia. This was a repeat of a survey that we had run in 2019, and we ran this survey for the second time in 2024, so 5 years later, to check how things have changed with the perception and the realities of stigma around the world. We did the survey with the support of the London School of Economics and surveyed over 40,000 people living with dementia, carers, healthcare practitioners, and the general public. We had replies from 166 countries, and people participated in the survey with 35 different languages. Next slide, please. You can download the report from our website by just scanning this QR code. So if you want to take a picture of it and scan later or scan now, that's how you can get access to the World Alzheimer's Report. Whilst you're doing that, I remind you that you can introduce you in the chat. I can see a lot of people already introducing themselves in the chat. That's where we know who we are. So thank you for doing that. And then if you have questions, please post your questions on the Q&A because that helps me distinguish our lovely greetings to each other from the actual question and answer that we will be taking with the panel later. So next slide, please. I think the most incredible finding of the World Alzheimer's Report was the 65% of health and care professionals believe that dementia is a normal part of aging. And this was up from 62% in 2019. I have to tell you that I really hope that this would be a result that wasn't to be repeated. Perhaps we got it wrong in 2019. But sadly, this is the situation we are now. So in the health and care professional training, this is doctors and nurses to you and I, there isn't enough information about dementia, and people still think that Alzheimer's disease, the frontotemporal dementia, are actually just part of normal aging. And this cannot be right. We need to do something about it, and governments really need to take this on hand in the training of their healthcare professionals. Other findings, next slide, please. Lots of other findings. 80% of the general public think dementia is a normal part of aging, and that's a dramatic increase with 66% in 2019. Between 29% of the general public in high-income countries and 32% in low- and middle-income countries felt that people with dementia are dangerous more often than not, and that was an increase from 2019. Next slide, please. Next slide, please. Over 64% of the general public believe that people with dementia are impulsive and are unpredictable. that over a quarter of respondents from the general public expressed the belief that moving a family member with dementia to a care home, even against their wishes, would be the best option. And this number sadly increased significantly in lower and middle income countries since 2019 from 9% to 33%. Next slide, please. And these findings, we go to the core of the report. You really need to read the report to understand the difference between anticipated discrimination and other form of discrimination. But we had results like 88% of people living with dementia indicate experiencing discrimination, and that was up from 83% in 2019. The anticipated discrimination increased by 10% since 2019. The people with dementia, 36% stopped applying for or continuing work, 29% avoided or discontinued close personal relationships, 31% avoided social situation due to concerns regarding the reaction of others. And of the carers, 43% stopped inviting friends over due to concerns about how they may treat their loved one. 47% stopped accepting invites to visit friends or family. And finally, over a quarter of people globally believe there is nothing we can do to prevent dementia, with an increase from 2019 to 37% in LMICs. So as you can see, this is despite all the work that we are doing on raising awareness about the importance of social inclusion and the importance of maintaining healthy mental health and how social relationships are very important. Dr. Shana Stites from the University of Pennsylvania will delve deeper into these finds later on this webinar. I'll continue to read you some of the findings. More than 90% of carers and respondents from the general public say they would be encouraged to get a diagnosis if a disease-modifying treatment was available. 85% of health and care professionals say they would be encouraged to give a diagnosis that was a treatment that could prevent or slow the progression of dementia. More than 80% of the general public believe that they can change the support provided to people with dementia through their vote, which is really important to remind that people are starting to get a conscience of the fact that they can put pressure on their politicians through the ballot box. Next slide, please. Among the general public, most respondents felt more confident to challenge stigma and discrimination than they did in 2019, especially in high-income countries, 64%. That's an important and significant finding. It means that something is happening. Over 58% of the general public believe dementia is caused by an unhealthy lifestyle, and this number increased since 2019 across high-income countries and upper-middle-income countries, although it decreased dramatically in lower-income countries from 78% in 2019 to 58% in 2024. Next slide, please. This tells us something also about what we can do to leverage better risk reduction, which, as you can remember, was the subject of our World Alzheimer report last year. But with that, I've concluded my section discussing the findings of the World Alzheimer report, and it is my great pleasure to introduce you to my co-panelists. And I also thank all of you that are introducing yourself on the chat, and I remind you to send your questions to the Q&A. So I welcome here with me on the panel Dr. Shana Stites, the Assistant Professor of the Department of Psychiatry at the University of Pennsylvania in the USA. Natalie Ive, a dementia advocate and ADI Global Dementia Expert Panel representative from Australia. Lebo Moleti, a carer and Atlantic Fellow at the Atlantic Institute, and he's based in South Africa. And Susan DeSanti, Executive Director of External Stakeholder Engagement for Alzheimer's Disease in Global and Medical Affairs at ASI, also based in the USA. I really thank all of my panelists also for being with me today in hours that are very unsociable. So thank you very much for being with me. And with that introduction, I ask for the next slide, please. And it is my pleasure to hand over the floor to Dr. Shana Stites, who will tell us about her contribution to the World Alzheimer Report this year. Shana, the floor is yours.
Thank you very much. It is a pleasure to be here and talk with everybody. I will be presenting data from 3 studies during this talk, with the title of the talk being Going Out, Getting Tested, and Finding Out Stigma's Impact. So in broad strokes, it's stigma's impact on going in to be evaluated, getting tested for your risk status associated with Alzheimer's disease, and finding out what those test results are. Next slide, please. Again, I'll be talking about 3 different studies. I'm a little light on the methods on these slides because I'd like to focus really on what the results are. So I'm happy to clarify at the end. For the first study, we asked people from the general public in the United States, about 1,200 people who identified as either white or Black in the US, to read a vignette about a person who was going into a memory center to be evaluated for memory problems. After reading that vignette, they completed the FS-ADS, the Family Stigma in Alzheimer's Disease Scale. And what we found were that individuals who identified as Black endorsed stronger stigma reactions to that initial visit at a memory center across all 7 domains of the FS-ADS. That is, they expected that the person in the vignette would experience greater social distance, more pity, more support, possibly to the point of paternalism, antipathy, those are negative feelings, negative judgments against their aesthetics, worse judgments than would be expected about the severity of their symptoms, and they would experience structural or institutional discrimination. And again, that was just on the judgment of going in to be evaluated as a memory center. And these findings are consistent with what we see in the US, in that individuals who identify as Black face worse healthcare disparities and are less likely to go in and be evaluated for dementia, even though they're more likely to actually have dementia. Next slide, please. So what happens when somebody makes it in, they actually get tested? Well, these here are data from a clinical trial, people who were undergoing screening to participate in a prevention trial. That is, everyone, about 290 people, went in, had their blood drawn, and were tested for ApoE, which is a genetic risk for developing late onset Alzheimer's disease. Before they received the result, we asked them to complete the social impact scale that had been modified to ask specifically about dementia. And what we found was those individuals, some of them had received the result, so they knew whether or not they were at a heightened risk. Others were asked to complete the instrument based on their expectations if they found they were at heightened risk. And what we found were those people in the hypothetical group, so they had been tested, but they hadn't yet learned their risk status, reported higher worries about stigma across all of the items. That's that upper row going down. Across all of the items on the SIS compared to those people who actually learned the result and were up to about 3 to 4 months out from learning that result. And they were completing the measure based on their experiences. So in summary, those people who were tested and waiting for the result were anticipating facing a lot of stigma, more so than even what people who had learned the result were experiencing. Next slide. And actually, when we look closer at the results in that study, we found that the worries that people had were, in broad strokes, mirroring the experiences of people who actually learned they were at heightened risk. And again, it doesn't match perfectly, but you can see some of the highest worries that were anticipated were also amongst those that were actually being reported as being experienced, where those that were less often concerns were on the lower tail of people who were reporting not experiencing those issues at all. Next slide. And we also looked, well, whether these reactions differed by the result people learned. So if you learned you were at higher risk because of an ApoE E4 gene, were you experiencing greater stigma than if you learned you were at a lower risk? And actually, well, these are small group sizes, so there's wide confidence intervals. What you see is it's similar, whether or not, regardless of the objective risk, people were encountering stigma based on undergoing ApoE testing. Next slide, please. And then finally, we did another study in the US public where we gave people a vignette, again, about a memory center. We had them read that vignette that described that the person went to a memory center, and then they learned that the person in the vignette either received a positive or a negative biomarker result. Okay, so the vignette they read either described a positive result or a negative result. They completed some other measures, and then one of the last measures they were asked described four scenarios for medical evaluation, which are here on the slide, for making a diagnosis of dementia. Scenario A was the clinician gives you a clinical history interview and a physical exam. The next scenario is a clinical history interview, a physical exam, and memory tests. The next one is similar, except that it adds in blood tests. And then the last one is that the diagnosis is made on a history interview, physical exam, memory test, blood test, and a brain scan. And after each one of those scenarios, it asks the person to rate how confident they would be if they received a diagnosis based on that testing profile. Not surprisingly, we found that the more tests that were used, the more confident people would be in receiving a result. So people who said that they would be diagnosed with dementia based on all of these tests and the interview were far more confident in that diagnosis than people who received a diagnosis would receive a diagnosis based on only an interview and a physical exam. What we didn't expect to find is that people who read the vignette about a positive biomarker versus a negative biomarker actually expressed more confidence across all of these evaluations. This result seems to suggest that simply talking or having a person read about a positive biomarker result is enough to shift some of their downstream perceptions of what they think about diagnosis and how confident they are in a diagnosis. And unsurprisingly, the more confident a person is in a diagnosis, the higher their ratings of stigma, both experienced and anticipated. Next slide. And with that, I'd like to thank you for your time and for your attention. And there's a QR code here to read about some of these studies that I briefly talked about today. Thank you very much.
Thank you very much, Shana. That's a super interesting presentation. This really gives you an insight about a lot of what we talk about in the report. And I would suggest that some of you ponder about this. Some will have read this intervention in the report, and then think carefully about how to phrase your questions around that, because I'm sure that there would be some. Now, I have read whilst Shana was speaking in the Q&A, a lovely message about Dr. Francisco Lopera. Perhaps it is the time to stop a second and remember three of the most important of our founders and followers in the last few years sadly passed away. Dr. Francisco Lopera from Colombia was a great researcher and was instrumental to some very important findings about Alzheimer's disease. I remember being on a panel with him in Guatemala and having a wonderful time and getting to know him then through the years. But we also lost the wonderful Pamela Brereton that was with us in so many webinars. She was the founder of the Barbadian Alzheimer's Association. So I think we need to have a spare thought for the wonderful Pamela and so much she's done for the development of Alzheimer and dementia cause in the Caribbean. And last but not least, Gabriella Salvini Porro, the founder of Fondazione Alzheimer Italia, who again has been a trailblazer in the workings to do with dementia and Alzheimer in my home country in Italy. So yeah, sadly, we have lost recently three very, very important figures. So thank you for raising that in our Q&A. Can I encourage everybody to send their question to the Q&A? We will pick them up at the end. Now, it is my pleasure to introduce you to Susan DeSanti, who is the Executive Director for External Stakeholder Engagement on Alzheimer's Disease at the Global Medical Affairs Department in ASI in the USA. Susan, it is my pleasure to give the floor to you. Over to you.
Thank you so much, Paola. And thank you so much for all the work that you do. And ASI is really very delighted to be invited to speak at this webinar. Good morning, good afternoon, and good evening to everyone. You know, when we think about Alzheimer's disease and the impact that it has on the community, we have to refer back to the fact that there are all these negative perceptions, as both Paula and Dr. Stites has said. And these attitudes that society hold toward the individual and the condition and certain conditions is extremely important. So in the context of Alzheimer's disease and dementia, the stigma can lead to a misunderstanding and a fear, not just from the general public, but also within the family and the community themselves. And it could have serious consequences. Many individuals will hesitate to seek help or to pursue a diagnosis because they fear being labeled or judged, not only by society, by work, by their families, but even by themselves, as they fear the loss of their independence and call that into question. The delay that they will experience in seeking professional evaluation can help prevent them from accessing the crucial treatments and support that could significantly improve their quality of life. How ASI is addressing stigma that's associated with Alzheimer's disease and dementia is that we firmly believe that patients and families are the driving force behind healthcare, and their perspectives really matter. Our company has a commitment to this disease state, and it's rooted in the principle that patients and families come first. We see this as our responsibility to listen, to learn from, and to empower patients and their families through our human healthcare mission. We at ASI do this by engaging regularly and directly with patients and care partners, the advocacy community, and all the members of the Alzheimer's disease community to understand the specific needs, the concerns, the fears, and the hopes of the patients and their families. And we strive to explore the community's misunderstandings of Alzheimer's disease that lead to stigma. Through these interactions, we can begin to address some of these challenges. As we know, the impact of stigma on patients is profound, and the fear of being labeled with a diagnosis of Alzheimer's disease and dementia is often immediately associated with the loss of independence for the patient and their care partners. Additionally, the lack of education surrounding what healthy aging versus cognitive decline is can manifest as a patient thinking, it's not serious, I'm just getting a little old, or ultimately refusing professional and care. As such, these stigmas or lack of education can lead to significant delay in diagnosis. And as we know, early intervention can be critical in slowing the progression of Alzheimer's disease. Yet when patients avoid seeking help, they miss out on these vital opportunities. Moreover, stigma can contribute to social isolation. Patients may withdraw from social interactions of work. They're feeling embarrassed or judged. They can exacerbate feelings of loneliness and worsen their mental health by withdrawing from social interactions. And this isolation could be particularly acute for individuals from diverse backgrounds, where cultural factors further complicate their experience of the disease. Care partners play a crucial role in supporting the individual with Alzheimer's disease, but they also face the burden of stigma. They can feel emotional strain, grappling with their feelings of inadequacy or shame. It could lead to them feeling burnout, making it increasingly challenging for them to provide the care that their loved one needs. Additionally, stigma can prevent care partners from seeking out their own support that they might require, whether it's connecting with local resources or finding emotional support from other caregivers. Fear of judgment can create barriers with increasing essentials so that they don't access essential services. So how can ASI begin to address these needs with the patients and the families? It's crucial to understand Alzheimer's disease at a macro level. We must also focus on the individual's experience and the community needs. Factors such as location, where somebody is it rural, suburban, urban, their race, their culture, their economic status can significantly influence a patient's experience and the resources available to them. It's also essential to acknowledge that the cultural beliefs and differences that exist within the Alzheimer's community, they can greatly affect how an individual experiences the disease and seeks help. Besides, unique corporate philosophy inspires not only us to advance treatment, but also to enhance care by providing educational resources and practical solutions to patients, families, and the healthcare providers. Our discussions with stakeholders have highlighted the pressing need for education and a comprehensive support system. Patients and care partners require guidance throughout their journey, understanding what to expect as the disease progresses, knowing what services are available, and being educated about treatment options. Our team educates healthcare professionals such as primary care physicians and community neurologists on these topics. Our philosophy is that we should aim to break stigma early in the first step of a patient's diagnostic stage through conversations with the primary care physicians as well as the patient and the care partner. And that can be done by educating physicians. In this spirit, we are proud of our collaborations with advocacy organizations like the Alzheimer's Disease International, who work so hard every day to provide necessary education and information addressing these issues in the community. I think I'm coming to the end, or do I have a few more seconds?
You do have a few more seconds.
Okay. So the one thing I want to talk about actually is that ASI takes an approach to bring patient-centered, patient-centric hope and optimism to the forefront of the scientific community. And we did this in two conferences, at the Alzheimer's Disease and Parkinson's Disease Conference in 23 and 24, where we developed a medical activity that incorporated all the scientists at the conference to work with us together to highlight clinical meaningfulness of treatments and the activities of daily living that can be impacted with a diagnosis of Alzheimer's disease. The attendees folded cranes and cherry blossoms, and we had impactful conversations on these two topics. And they were reminded that these are the conversations and the issues at the forefront of the patient and the care partner's mind. And in the end, these creations were installed permanently in local memory facilities where patients and care partners could see these beautiful works of art and could be reminded about how they and the importance of understanding the disease is at the forefront of ASI's mind. I thank you for your time, and I look forward to the continued discussion on this vital topic.
Thank you so much, Susan. Quite a lot of points raised, especially on that tricky point of the education of healthcare professionals. We are in good time. I can see there is still a lot of presentations of introductions of people coming on the webinar. Thank you all for telling us where are you from. We really enjoyed that. Can I also remind everybody, please, to post the questions for the speakers in the Q&A. We are going to pick up some of those questions at the end of the webinar when we'll have a little bit of time for a discussion. So it is my great pleasure now to introduce you to Lebo Molete, who is a carer himself and is also an Atlantic Fellow at the Atlantic Institute. Lebo is based in South Africa. Lebo, it's a pleasure to have you with us, and please, the floor is yours.
Thanks, Paula. I hope everyone can hear me. Am I audible?
Yes, loud and clear.
Right. Thanks again to the ADI for inviting me to speak in my capacity as a caregiver. I will not claim that I represent all South Africans here, but certainly some of the things I'm going to say will resonate with some South Africans who are here. I want to speak about attitudes and stigma to dementia, which also is closely associated with the title of the 2024 report that's out. And yes, apart from being a caregiver, I'm an advocate. This has just started recently, and I'll talk more about that. Next slide, please. Okay, so this is what I want to achieve today. Just want to briefly talk about my personal journey as a caregiver, the unique circumstances that prevail in South Africa, particularly in Black communities, where I come from, and insights from the report, as I stated before, about attitude to dementia, and what I hope for, which might help reduce stigma and to mitigate dementia. Next slide. Go to the next slide, please. Yes. All right. My ignorance and difference in caregiving. So that's the picture of my father who was diagnosed with frontal lobe dementia just over 2.5 years ago. And sadly, to state that, well, he's still alive, but he was discovered late. And this is something that we always suspected, but we're not sure what it was. So when we discovered what it was, my family was divided in half regarding what dementia is, what the cause is. And I think it happens to a whole lot of families. And it didn't just divide the family. So there was isolation and lack of support, not just from the community, but from within the family as well. So a quarter of the family have not seen my dad since he was diagnosed. It says a lot about their beliefs regarding dementia. And from that point on, I decided I want to learn a lot more about this and take it head on, not just for me and my family, but for a whole lot of other people who may be in the same boat as me in my community. Next slide, please. So I just want to tell you about my understanding of dementia, and it's important that I do, because before my dad's diagnosis, I did not know not a little bit about what I'm bringing to you, although I consider myself having a relatively good education, but this was not apparent to me. So dementia is a progressive brain condition. It's important that it's named as a brain condition which affects memory, cognitive skills, and more importantly, social relations. It's not just affecting the person who lives with dementia, but everyone around them, family and the community. And the factors that determine dementia are not just biological or medical, they are also social. So these include economic, cultural, very important, spiritual, dare I say, and political factors that I'll talk more about later. Next slide, please. So stigma and dementia, and as I said before, I want to focus a lot more on Black communities because up to so far, it's been one huge sector of the community that's been neglected, dare I say, by government, but ourselves as well. So in Black communities in particular, dementia is regarded as a cultural, spiritual taboo or a curse. We dare not talk about it openly, but this is one thing I want to challenge quite a lot more. So dementia is seen as a form of witchcraft, and this happens a lot more out in rural areas and in some poor urban communities as well. I won't dwell too much on this. I'll keep referring to it when I speak about the spiritual aspects of dementia. So for that reason, the community is reluctant to acknowledge and discuss dementia. Very few people dare to speak about it openly. So there are effects that include isolation, and that has a profound effect on families like mine, families of people living with dementia. And this is because there's a huge misunderstanding that isolates families, and it acts as a barrier to seeking support, whether in the community or in the public health system. And there's a concept of Ubuntu, I'm sure the world has heard about this, which is a sense of community that has existed in the African context for a long time. But I'm sad to say even that is not helping quite a lot. It's lacking, especially when we have to deal with dementia. Next slide, please. So there's a huge impact on dementia care in South Africa, and one of the reasons for this is that there are very scarce resources, and I'm talking about human as well as financial and medical resources in South Africa. And families of people living with dementia encounter systemic, not just in their families, but system-based barriers and in society that act in their way of seeking care. And dementia is, like I said, is not a public health priority in South Africa. It does not rank in the first 10, which is tragic. And I think there are reasons for this, and I hope to talk about that more later. And this is borne by the fact that we don't have a national dementia strategy, which would help in dealing with dementia at a public health level. And so there are much fewer dementia champions and advocates in South Africa, particularly in Black communities, than I would have liked to see. Next slide, please. Now, if I can go to the report. Now, this slide is slightly wet. I'll just try and go through it. There are findings that are on the report, and I've tried to think about them in the South African context as well. Start with knowledge. So, like Apollo read right at the beginning, dementia is regarded, with no set statistics really, regarded as a normal part of aging. And in South Africa, there are added components and elements, not just regarded as part of a normal part of aging. There are cultural, spiritual beliefs that determine how people see dementia. And in terms of findings in the report, early medical diagnosis helps in management, and that's a fact. And a whole lot of people would love to see that happen. But in our case in South Africa, there's, particularly in the Black culture, people would rather go to a traditional healer first or go to their church to try and find out what it is that's bugging either themselves or their family before they seek medical help. So there's a longer path to a diagnosis. And the report also stated that more can be done to improve the lives of people living with dementia. And in our context, families are solely responsible. In other words, when someone has an ailment, particularly brain health, that's less understood, that the responsibility is left solely to the family, not so much to the community, not so much to the public health system. So in terms of attitudes that were spoken about in the report, the general public in high-income countries and low middle-income countries believe that people living with dementia are dangerous more often than not, and that was stated very clearly in the findings of the report. And in the context of where I am, people living with dementia are often isolated and marginalized because their medical condition or their condition is associated with the taboo to do with culture or spiritual suspicion. And again, the idea of attitude that was mentioned in the report, where people living with dementia can be moved into a care home as a best option. That is the opposite of what we see in South Africa. So it's always been a century-old who taking parents into a care home. And I remember even in my case with my dad, who had, while he was still really well functional, had warned us against this. And in terms of behaviors mentioned in the report, people living with dementia and they experience a great deal of social discrimination. Needless to say that that's the case in South Africa, and it's not just individuals who live with dementia that are isolated. Families, those who care for them, are also included in the suspicion that is accorded to people living with dementia. And lastly, in terms of behaviors, in mentioning the report, people stopped inviting their friends over, and that's the case here in South Africa. Families, even in my case, people are not willing to divulge the status of their loved ones, especially if they live with dementia. Next slide, please. So pathways to mitigate stigma in our communities. I think there are three main ways, and this list is not exhaustive. Education and awareness. These are crucial because of the erroneous beliefs that are based in culture and sometimes in spirituality. So awareness campaigns to dispel these myths and to reshape just the perceptions of dementia. There's a great deal that has to be done beyond the individual, beyond the community, up to the government level, where policy influence has to be a large component of dealing with stigma. We're working with policymakers to support reduction policies and advocacy from the community-based levels, NGOs, support families that and caregivers like myself. And I cannot overemphasize the support networks that are needed at a local level for groups of caregivers to share experiences and solutions. Next slide, please. One of the things that I'm interested in, and I decided to take this on, I've had this brainwave for quite a few months now, is to go on a research from January on, to try and investigate how conditions are named. In Africa, in fact, there's an idiom that says you can't treat a disease that you cannot name. And that's true. So the biggest challenge is the language and the framing of dementia in African context. As a matter of fact, I think about 70 to 80% of languages in Africa do not have a name to conceptualize dementia. That's the reason why it's pushed aside, and in most cases, as we would also refer to it as a Western condition. So the words and cultural beliefs go a long way in shaping an understanding of a response to any disease. We've had that instance in South Africa where for many years, for a decade or so, HIV was not named in any African language. Until that happened, I'm not saying that was a solution. It shifted a whole lot of narratives and beliefs until and people could freely deal with it and openly so. So an understanding of how local terms and cultural framings perceive dementia, but also, as I said before, it's not just a medical approach that will help, but a combination of cultural response and evidence-based approaches, hence the research, and that might go a long way in reducing stigma and changing the narrative around dementia. Next slide, please. Okay, so right at the end, I just want to reiterate that stigma is a major barrier, not the only one, to dealing with dementia, especially in Black communities. And to mitigate it, we need to build awareness, education, encourage open dialogue as much as possible. So, and I'm glad that we have so many people here, not just panelists, but people from all over the world, as a call to action that I'd like to collaborate with us, with this country, this continent, so we can take action through education, awareness, advocacy, and to support in any way possible. And because I think, as I said, it's not just medics or the public health system that can dismantle this stigma, but everybody in collaboration. Thank you.
Thank you very much, Lebo, for this great presentation that really gave us a very strong sense of the content of the challenge around stigma this day in Africa. And I can see that in the chat line, there are some comments on it. I also welcome any question that you may have for Lebo. Please, in the Q&A section, which I can see is becoming richer and richer of questions as the time goes. I also, before handing over to the next speaker, would like to remind you of the ADI report on dementia in sub-Saharan Africa that we published in 2017. It is a very hard-hitting report with a lot of facts and figures around dementia in sub-Saharan Africa. I think Michael is putting the link to this report right now in the chat. Also, I'd like to remind you that we do have a member in South Africa, Association for Dementia and Alzheimer's of South Africa, MPC, ADASA, and therefore, if you have any questions, also please address them to them. The address of ADASA will be on our website. So thank you very much. I'm going now to hand over the floor to a passionate advocate for dementia, Natalie Ive. We were together in Spain recently, and so I had the opportunity to get to know Natalie better, but also to give her a big hug. I miss not being able to hug people on the webinars because we are all so far away and they're online, but this is the best way for us all to be able to reach you from so far away, also creating the possibly least impact for our little and resource-hungry planet. So it's a nice way to be together. Natalie, thank you very much for writing a beautiful essay that you wrote for the report, and thank you for being with us today. So Natalie, the floor is yours.
Thank you for that warm welcome, and it's really an honour to be here, even though it's 12:45 a.m. in Australia. That's true dedication to dementia awareness, so thank you. My name is Natalie. I live in Melbourne, Australia, and I was diagnosed with primary progressive aphasia in 2021. I am an educator with extensive experience in both mainstream and special education. In addition to my teaching roles, I work as a freelance research advisor with universities, collaborating with teams on various research projects. I also sit on the Dementia Australia Advisory Committee and am one of the board directors for the Australian Aphasia Association. I was recently appointed to represent Australia on the ADI Global Dementia Expert Panel. In my experience, very few people have heard of aphasia, and even fewer about primary progressive aphasia, a language-led dementia that affects all aspects of communication: talking, understanding, speech, reading, writing, and using numbers. As the disease progresses, mobility and swallowing issues can also arise. It's important to note that the symptoms of PPA can vary from person to person, and the individual's intelligence is unaffected. Timely diagnosis and intervention are essential for effectively managing dementia progression and significantly improving the quality of life for people affected. My GP has been supportive of me throughout my journey so far. However, when I first attended the hospital, I felt alone in my journey when I lost my ability to speak and did not know my surroundings or the names of my family members. My family could see that the neurologist team weren't interested. Instead, I was prescribed an epilepsy medication for anxiety, which I did not have and did not take, by the way, as no formal mental health evaluation was conducted beforehand. At my age, it was hard for doctors to believe that I could be facing something as serious as dementia. To make matters worse, after losing my surroundings for a second time, I found myself waiting in the emergency department with my family again for over 6 hours. It was frustrating not to be taken seriously, and ultimately, I was discharged without any real support or further options. My journey has been exceptionally tough. Even when others doubted me, it became clear that some doctors needed a course in sympathy and effective communication. I had to search for myself for a solution. Firstly, I would like to start by saying that I believe, and I'm sure many would agree with me here, that dementia is a societal shared responsibility. Addressing dementia stigma in healthcare systems is essential for improving the quality of care and support for people living with dementia and their families. As we understand, stigma arises from misconceptions that create fear, leading to social and community isolation and hindering access to essential services. Addressing these issues is vital for improving the lives of people living with dementia and fostering inclusivity. To combat the stigma surrounding dementia effectively, I believe strongly that healthcare professionals must undergo specialised training tailored to the unique needs of the person living with dementia. Such training should prioritise compassion and respect, equipping providers with the skills to communicate effectively and nurture a supporting environment. This, in turn, will make them feel equipped and competent in their roles. Furthermore, awareness is a powerful tool in reshaping perceptions about dementia. By sharing the stories of people with dementia, we can highlight their many abilities and contributions, empowering them and breaking down stigma. Engaging in meaningful activities and having a sense of purpose can significantly enhance the lives of those with dementia. Equally, involving caregivers in discussions about their experience can empower them and promote understanding and awareness of dementia. Moreover, implementing dementia-inclusive policies within healthcare systems is essential for making services accessible and equitable. This involves creating environments that meet the needs of individuals with dementia, such as quiet areas for calming breaks and simplified navigation with clear signage. By enhancing these aspects, healthcare systems can reduce confusion and anxiety, ultimately improving the overall experience for those affected by dementia and their caregivers. Living with an invisible illness myself presents unique challenges, especially when others overlook the seriousness of my PPA diagnosis. This lack of understanding can be both frustrating and deeply hurtful. Many assume I'm managing well because I appear fine on the outside. They often fail to see the extensive preparations I make each day and the effort required to handle my responsibilities. People only see a snapshot of my life, not the complete picture that spans 24 hours, 7 days a week. I need support at work, in my community, and at home, and having this support can significantly impact my well-being. I'm grateful for my assistance through the National Disability Scheme in Australia, my family and friends, and the support of Dementia Australia and Dementia Alliance International, and lastly, ADI, which all make a big difference to me. Now, I will leave you all with this last thought. Many have told me, you don't look like you have dementia, Natalie. I had such an experience at a recent dementia research conference. I was asked about my affiliation, and I explained that I'm a person living with dementia, and I'll be presenting and speaking on a panel shortly. He said, you don't look like you have dementia. I asked, what does dementia look like? He responded, not you. This came from a professor. It is deplorable that people living with dementia face discrimination in all aspects of their lives, and this stigma continues, whether intentionally or through ignorance, by some within the dementia medical sector. Unfortunately, this common phrase intentionally perpetuates stigma and stereotypes. The words we use affect how people with dementia are perceived and treated, and impact the support and empowerment they feel within society. Thank you.
Thank you, Natalie, for your strong voice and your strong presence, and also for raising the profile of primary progressive aphasia, which is one of the rarer forms of disease that leads to dementia, and that so many people don't know anything about, and that is so hard to get diagnosed with. For those of you that will have been pondering about the journey that Natalie has described, that journey is not unique. This is what we hear over and over again from people living with dementia that have to go through it, obtaining a diagnosis everywhere, not just in low-income country, not just in middle-income country, but everywhere is still a challenge for most people. And it's so important, we hear it over and over again, to obtain a diagnosis. We did write extensively about this in the World Alzheimer Report 2021 on diagnosis, and the World Alzheimer Report 2022 on what needs to happen after diagnosis. There should be no diagnosis without post-diagnostic support, as Natalie told us, for those that go through a diagnosis. And I want to remind you also that in the report 21, it also highlighted how easy it is still to receive a misdiagnosis in dementia and Alzheimer. And this is part of why we still have issues around stigma, and part of what Natalie described herself. And the reason why we do now have an advisory panel of people living with dementia, with all kinds of dementia, at all stages, that can advise us on how better to represent the interests of a community that is very different, and where people can live with a diagnosis for a very long time, especially if right now is more and more frequent people are diagnosed that way. So Natalie, thank you so much. Now, I would like to pass to the next bit of our webinar, which is going to be questions. Now, I have a lot of questions in my inbox, and I thank you very much. I know more of them will come as we continue the discussion. So I'd like to sort of bring you back to the beginning of this webinar, and I'd like my first question to be to Dr. Stites. It's a question from an anonymous attendee that asks whether through your research you will develop recommendations on best practice for communicating risk to individuals to avoid anticipated stigma, something that is easy to follow for healthcare professionals. I think this is a brilliant question, because remember, what we do at ADI is all practical. It's how to translate what people study in academia, in research, into things that people can actually do on the ground? So this is a brilliant question. Please, Shayna, would you like to answer the question directly?
Yes, that's the short answer. So yes, the results of my studies are, one goal is to use what we're learning in these studies to inform what should we be talking to people about during the disclosure process. At what point does the disclosure process begin, right? Is it as people are thinking about undergoing testing? We need to start talking at that point, right before they even get in the door. And then clearly, some of the results in the studies I was showing you there is people are suffering under the weight of anticipating that the result. And what's coming out of the studies I'm conducting and some other people are working on is what we should be talking to for people there. I didn't have a chance to go through all the results. But the difference in those two groups are between people anticipating the result and people who learned the result. And as they learned the result, they went through a disclosure process that I helped to inform some of that, what was done in that disclosure process. And you can see the stigma was much lower amongst people who had learned the result. And I'd like to think in large part that was because of what was discussed in the disclosure process, right? That becoming more informed about what results mean and what the disease itself means did lower the anticipated stigma. We had some pre-post comparisons that showed that. So yes, the other way that these results are being used from the study is to inform general anti-stigma campaigns. There have been campaigns to reduce stigma, and sometimes they have unintended consequences. So being able to develop ways to reduce stigma that are effective is super important, and we have to use data to do that. So those are the two goals of my research. Thank you for the question.
Thank you. And as you pointed out, there can be unexpected consequences to us having anti-stigma campaign. Would also like to point you out to the fact that as part of one of the projects that we were involved with, the STRIDES project, there was an excellent anti-stigma tool that was developed. But once again, you should really read the report because, again, what we do can have consequences that are not what we expect them to be. And in stigma, there is a lot written pro and against, and the way that you go about sort of tackling your best intentions doesn't necessarily match what then happens as in the course and after the course of your intervention. So thank you very much, Anna. There may be other questions specifically on that, but in the meantime, I'd like to bring the spotlight on Susan DeSanti. Susan, there is a great question here in Spanish. Now, I realize that because we offer translation in so many languages, now people are starting to write questions in a lot of languages. Now, I only speak 5 languages, so there are languages that will be beyond me, for which I might need myself AI translation, but this one I can take. So they're asking, what is the perspective for pharmacological advances in Latin America, given the current context, social and political? We've been talking about Francisco Lopera and his lovely research. Do you know anything about what's happening specifically in Latin America, where there are interesting sort of research advances?
Well, pharma companies are always doing clinical trials, and they do include countries in Latin America. And specifically for ASI, we have been working in Brazil and Argentina, and so within that those countries, we have been able to work with patients and their families, and will continue that in the future. In a clinical situation as well. So not only the research, but also clinical.
Lovely. Thank you very much, Susan. There is quite a lot of other questions. I'll get back to you on that. But it's always a joy to hear that there are clinical trials beyond high-income countries. This is something that ADI has been working a lot on. And that is why it's so nice also to encourage always industry to bring clinical trials away from the usual places where those trials happen. Lebo, there is a very interesting question for you, and this is one from Pat Brown. She says that she delivers dementia training to their live-in-home care workers, most of whom are from various states within Africa. Your presentation resonated with her experience of trying to raise awareness of dementia through her training. Do you have any suggestions of how she could use more culturally specific aspects to improve the training and awareness for their carers? Thank you, Lebo.
Thanks, Paula. It's a great question. I don't think I have a definite answer on that one, but based on my experience as a caregiver, but also in my experience as an advocate, I have noticed that the current forms of training that we have, either in care homes or even in nursing colleges, whatever, is Western-based. Nothing wrong with that. However, it lacks other components that I spoke about. For instance, they are contextually based, that are cultural, which could go a long way in helping. So, in terms of integrating cultural aspects in existing curricula, I think there's a lot of work being undertaken as I speak. There are other methodologies that are being used. I have not seen one that's out there. Matter of fact, a few advocates from the Atlantic Institute are deciding to bring a curriculum that would be contextualized, that will have an Afrocentric look at how current curriculums can be upgraded and to include cultural aspects in it. That's still work in progress. And I would ask her to just say one, but that's very, very important. We don't have to indefinite. It's a great question. Thanks, Paula.
Thank you very much. Sorry, my audio had disappeared for a second. Can I thank you, Lebo, for this great answer? I would like to ask the next question to Natalie. Natalie, there is a lovely question from the chair of ARZI, our Indian association, Renu Vora, in the Q&A. Renu asks, educating younger generations on how they can contribute to inclusive, compassionate communities. Can awareness programs in school and colleges help? I know you've had experience of this, so could you tell us something about Australia?
Yeah, look, I'll try and answer this as best as I can on the spot. I believe that it's essential that children start learning about neurodiversity more broadly and dementia within childcare, primary and secondary education. It's imperative that they know and understand. So that's all I have.
Thank you. Thank you very
much.
much.
I can answer that over an email in more depth. So.
Okay, that is lovely. I can say to Renu as well that I have seen a number of really great programs being enacted. And in some countries, I've been to speak to education ministers directly as they were interested to implement those more broadly in the country. It's certain, a lot of our members have wonderful resources on engaging children and start educating them at a very early stage about what their grandparents or parents may be going through. There are also lovely organizations that specifically address young onset dementia, like Lorenzo's House, and they are clearly engaged in trying to make sure that the younger generation is better aware of what could be going through the older generation. So thank you so much. Now, I have a question here on for Susan. Somebody's asking whether there are any future scheduled medical exercises as the one you described in other conferences. And another question is about how can people engage with ASI and other companies to raise awareness?
So I'll take the question about raising awareness. So we have an advocacy organization, and that they can contact me, and I can put people in touch with our advocacy group, so that we're always looking to engage with people, especially on issues about education and about stigma and Alzheimer's disease. And with respect to the exercise and the activity that we did at a Congress, so ADPD and at the Alzheimer's International AAIC conference, we always have activities, medical activities, where we really try to engage our, and bring forth our mission, the human healthcare mission that ASI has during those. We have one coming up in April, and right now we're in the process of thinking that through and kind of creating the next activity. And we'll keep you posted, Paula, and then you can share this with your, your folks. And so whoever happens to be at those congresses can join us for these activities.
Lovely. Thank you very much, Susan. Always interesting for people to participate to those. The next question I have here is from a person that participated, that was a speaker at one of our previous webinars, the one where we launched the World Alzheimer's Report, and that's Brother John Richard Hagan. This is for Lebo. John Richard says, I agree on the importance of naming something, but what does one do to create naming while including all the Atlantic Fellows, advocates, organizations through the entire continent of Africa? It seems to me that many of the fellows I've met from different countries agree with the observation that there is no name for dementia, but it seems everyone is either talking about doing their own thing to change that or else not addressing it. It seems it needs to be addressed by all. This question was also reflected by a comment of Monica Kikinaud from our Kenya Association in the chat that I saw earlier. So Lebo, do you want to attempt to answer this really complicated question?
Thanks, Paul. It's going to be an attempt. But I'm glad that this question was raised because I think quite a few people, fellows in particular, Atlantic Institute, have been thinking about it, but we've not had a coherent strategy on how to even begin to go about it. So I've decided to take this head on, as it were, and I've written just a recent research idea down, and I've been speaking to quite a few, and I'm delighted to hear that also people in Kenya are interested in dealing with this. So we have 4 regions in Africa with diverse languages and cultures, and to attempt to have just one framing document wouldn't do justice for the entire continent. So I think it's going to require a whole lot of professionals, and work, as I said, has started on this, and certainly we're going to keep everyone updated. But it started off, as I said, with a basic document that I'm going to share. And I have also thought putting that involve the ADI, particularly the person of Wendy Weiner, who's in charge of research and publications. And this is what I'm going to share beyond this presentation, but certainly people will be updated on how this goes. It definitely has to be done in the next year or so, involving as wide a number of professionals as possible. But look out and watch the space.
Thank you so much, Lebo. It's a good attempt. It's a very complicated question to answer. We have a few minutes, and I have a really interesting question here from someone who is Professor Zaldivar from SUNY at Buffalo in New York State. The question is half for ADI, half for Shena, I would say, and probably Susan as well. He's asking whether we can recommend any reports focusing on Spanish-speaking countries and or populations in the US. So I'm going to answer the bit about Spanish-speaking countries. Pretty much all the reports of ADI have an element of Latin America. As you know, we have members in all Latin American countries with the exception of Paraguay. We still are wondering why not Paraguay, but that is how it is. So when we do our reports, we make sure that there is a perspective in those countries as well. Our Director of the Americas, Diego Aguilar, is listening in on this webinar. And Diego, probably you can also post some suggestions of which report may have more relevance, but nevertheless, again, every report will have an element. So I suggest you go to the ADI website and have a look at what is available, or somebody from the team will be posting a link. And now over to Susan and to Shena on whether you have specific reports that address populations, Spanish-speaking population, I presume, in the US.
I'd have to get back to you and to say exactly what the report is. We have educational material, and we have educational material that's translated into different languages. And if somebody is interested, they can contact me and I can share with the folks from our US medical team who would be able to provide that to them.
Thank you very much. Shana, would you like to add to that?
Sure. One thing I would like to point out, I know Lebo mentioned that South Africa is still lacking a national plan for dementia. With respect to this question, I know just as recent as last year, I believe, Brazil and some of the countries in South America have put together a national plan for dementia. So that might be a resource to look to. And then I have some data that I'd have to look for additional reports. I have some data on Latin Hispanic populations in the US. Papers are in the works, but conference presentations.
Thank you very much. We do have only a few minutes left. There is a question here from Eddie Hoffman in the chat, which is quite interesting. It says, stigma is a significant challenge in the UK and delays many people's diagnosis journey. Are ADI and the panelists aware of any efforts to address the challenge of stigma, delays in diagnosis, and drugs that are aimed at individuals at the early stages? It seems contradictory that there isn't more effort to reduce stigma by clinicians and research bodies with the aim to target early experiences of dementia. Now, would anybody like to take on that question from the panel? Any hands up? No hands up in particular. No, yes, Shana is trying to unmute herself.
Yeah, I'm sorry. So this is just to be clear, the question is around why aren't there more efforts to address stigma in early periods of the disease?
I think that is what the question is about. I can't speak for the person that asked the question, but that's what I made of it. Yeah.
I just wanted to point out, I know the Alzheimer's Association within the US has been very interested in this issue. And I have some papers out there. There's also been work from some folks out of Wisconsin. There seems to be quite a bit of emphasis, at least within the US, as we're getting more early testing to identify risk states. There's an increasing interest in addressing the stigma. There could always be more, but I just wanted to point out there are quite a few efforts in the US at this point.
And if I can offer a global perspective, of course, in countries which have been very advanced in timely diagnosis, it is clear now that there are more diagnoses of people with younger onset dementia. And the country that really springs to mind for me is Japan. And possibly the second country is South Korea. They are way ahead of everybody else in this area. And in a way, the stigma is changing as the countries are also putting together public health campaigns aimed at alerting people about the fact that they can do something from the point of risk reduction. So in a way, the two things seem to be going hand to hand. Mm-hmm. And the respondent here is speaking from the UK, which is where I live. And I cannot see, I'm afraid, in the UK and in many, many other countries, the same level of emphasis in public health campaigning. I myself went recently through a test in the UK for people that have passed a certain age. I'm not going to say which age. Out of curiosity, because I wanted to see whether they would test my cognitive function. And there was nothing. They were testing me for diabetes, hypertension, other stuff like respiratory diseases. And when I asked, are you going to test me for cognitive function? It was like, no, we're not, the government's not interested in that. So that tells you just how much work we have to do. This is ridiculous. And it goes against every possible recommendation that ADI has ever made in any of its reports. So we do need to work towards this. Susan, I want to say something about
that? I did want to say that, yes, early diagnosis and early treatment is really paramount. And that is one of the most important educational goals for many pharma companies that are working in the Alzheimer's space. To really not only, I mean, the experts really know this, but those that are generalists or those that are PCPs may not necessarily have the same understanding. And the importance, it is so important because if you can diagnose a person early, you have the possibility of stepping in and doing some treatments that could make a difference in their life.
Thank you very much. And to remind everybody, we always advocate for timely diagnosis, but at the moment, it's becoming clearer and clearer that there is a problem even getting a diagnosis. So this is all what we're trying to get to here is that it's important to raise awareness, because otherwise we'll never go out of this. And there is still so much work to do. You know, we speak to the converted here. A lot of you know what we're talking about, but our problem is still the millions and millions and millions and millions of people that have absolutely no idea what Alzheimer and dementia are. And this is why we do World Alzheimer Report. That's why we do World Alzheimer's Month, which is growing and growing. But still, our work is far from being finished. And with that, I would like to thank my panelists. There is a lot more questions in the questions. I knew this was going to be very exciting. There is a question about politics and dementia. Well, can I say we should have a webinar only on that? That's what ADI does, the in, the out. There is so much we can talk about in this area, but we will leave it for another webinar. I would like here to thank the team of ADI who has been with me throughout this webinar, in particular, Jane Ciborra and Megan Anderson, who have been with us in the green room organizing the webinar. They are putting now these slides that reminds you to keep connected with us in order to hear the latest thing we are going to do. We have a big event coming up in December. On the 10th of December, the ADI Forecast is a new initiative. Please go to our website and learn more about that. That will be the next very big online activities that you can join. Thank you for being with us. Thank you for being wonderful as ever. Thank you for such a clever, wonderful question. Thank you, Susan DeSanti. Thank you, Lebo Molete. Thank you, Natalie I. Thank you, Shana Stites, for being with me on this webinar. And goodbye to all. Bye-bye.